Welcome, everybody. I'll be periodically letting people in and out here as well. First off, thanks to everybody for taking time to join our webinar today. For those who don't know me, my name is Kieran Fitzgerald. I work for a company called M3 Medical, and we're a leading interventional distribution company based in Ireland and covering Ireland and the UK. I'd like to also thank Ken Mullins, who's the VP of Prytime Medical, and Dr. Chance Spalding, who is the CMO of Prytime Medical and also a trauma surgeon. So today's webinar is about innovating hemorrhage control, and in particular in using REBOA for partial REBOA in modern trauma and pre-hospital teams. So I guess with that being said, I'll hand it over to Ken and Chance, who will talk you through it, and we'd like to be as interactive as possible, ask as many questions, and the purpose of this is that everybody shares some knowledge and learns. So with that being said, I'll hand it over to you, Ken.
All right, awesome. Next slide. Well, my pretty picture's not up there, but you guys can see me. So Chance will be doing a lot of the talking here in a moment, but and then I'll let him introduce himself. But I'm Ken Mullins, like Kieran said, the Vice President of Sales here at Prytime, and we are so thankful and grateful to you guys for taking some time out of your busy day to join us in this conversation about something we don't know the name for it, and Chance will laugh about this, but the owner of our company, he's still looking for the name of what we're going to be talking about today, partial balloon occlusion. So Chance, I'll let you talk a little bit about yourself, and then we'll get moving to the next slide.
I'm Chance Spalding. I'm a trauma surgeon in Columbus, Ohio. I have a PhD in biomedical engineering. I've been doing some kind of bridge to clinical work with REBOA and aortic occlusion for a couple of years. David, the president of the company, asked me to kind of come on as the CMO 2 years ago now. So I've been able to kind of apply some of my engineering and my clinical background. I'll just say it's fun to see the group because I know a fair number of you. I know that a lot of you have just as much experience as I do with aortic occlusion. So this should be really fun. This isn't meant to be like a teaching thing that I'm kind of dictating what we do, but it really is going to be way more fun if you go through and we just talk about it because, like I said, half of you have a lot more experience than I do, especially in certain areas. So please feel free to chime in and let's have a fun conversation.
Okay, next slide. Okay, here's just briefly the objectives for today. So, like I said, we've already done the welcome. We're going through the objectives now, and then you guys have met Chance and myself. We're just going to start out with just a little bit of a brief overview of the REBOA technology, and then next we'll move into a deep dive of talking about the catheter. Basically, just a couple safety features that we want to highlight that I think that are something that it truly makes us a little bit different than anything else out there. And then we're going to move into some current slides of a couple of our observational studies, some really cool data that's coming back from them that I think is very valuable for you guys and for everyone in the clinical space. And then Chance is going to do a talk about a recent case scenario, and then we're just going to open the floor up. Like we said, very informal. If you have a question, raise your hand or chime in. We want to make this, like I say, conversational, and so we all learn. And if you guys have good, bad, or ugly experiences, please share those with us because we are a learning company and we want to learn from you as well as you guys learn from us. So next slide. All right, so has REBOA changed? So what with our old catheter, our plus catheter, what we saw a lot was right down there at the bottom. You're kind of tied into that 30 minutes time limit, and you're kind of in a salvage mindset. The old plus catheter was kind of used as a last resort. Didn't really have the utility that it was proven to be. I mean, this catheter was birthed out of a need in war and to control non-compressible hemorrhage. And we all know if we've been in any active conflict, 30 minutes to get this catheter in and to try to move them to the next echelon of care really is not enough time. So next slide. So what we see, the difference between our plus and our pro catheter is this bifurcation line. Our new pro catheter is starting to allow, such a different mentality of care, and that's what this is all about. This is a mindset. And one of the big things we want to talk to you guys about today is where you see early CFA access and early use of our catheter. So the key word today is early. So we want to talk about that. But you also see keywords up here: recessive adjunct, decreased blood use, improved mortality, prolonged aortic occlusion. So we're starting to see that trend, that bifurcation, moving away from salvage more to success and survival, vice being that old 30 minutes. And now we just got our most recent FDA clearance for partial occlusion, which we are allowed to say 2+ hours now in the US with the FDA. So next slide. So I don't know if any of you, most of you have probably heard, seen. I don't know if a lot of you have used the new Pro catheter, Pro balloon. But what we want to talk about here is just certain, key benefits and key features of the catheter. So our semi-compliant balloon, which that is we've got another picture coming up of the balloon, but the semi-compliant balloon allows you to do both full and partial. And when I talk about it, I say it's like the iPhone. It's, everything that the old iPhone could do, the Pro can do, but it does so much more as well. One of the other key features to it is the pressure relief valve that allows you to not really titrate too fast or over titrate. So we get kind of a flashback or a blowback, and any of you have used it will see that. And then we've got our enhanced zone markers for our landing zones, zone 1 and 3, and Chance will talk to you a little bit about that in a moment. And then we've got the integrated arterial lines. We can monitor both above and below the balloon. The above is integrated into the catheter, and the below balloon is on the sidearm. And then it's you can use image, and it's guide wire free, which facilitates very, very rapid deployment of this catheter. All right, next slide. So here's just a brief diagram. You guys can look at this. You see the safety valve. You see the balloon there, how long it is. You can see the atraumatic P-tip at the end on your left side there, and then you see the arterial port line there. So it's just a quick diagram of what the catheter looks like. Next slide. This slide is what I tell everybody is the money maker and is the difference maker. When you come up to our booth or something like that, we always have a couple of these catheters blown up. So there on the left side, you have our old plus catheter, and on the right you have our pro catheter. And so this is our opinion here. So this is what we're talking to here about intermittent and partial occlusion. We kind of think that our old catheter, the plus catheter, was kind of an intermittent. So the only way that you could get partial and stuff was an on-off switch. Whereas our new catheter, our partial occlusion catheter, it allows with the flow channels on the catheter, allows for blood flow to be to constantly be able to go, so you don't get that the distal ischemia and as much AKI is passed. You guys will have to forgive me. I had a dental procedure this morning, so I probably sound a little funny. I sound a little funny anyways because I'm from the South. So you guys can
always
laugh
sound funny. You're from Kentucky, man. Come on.
A little hillbilly there.
Not the U.S. Don't blame me. That's you.
So this is the shot that I think is the moneymaker. And then the two things here is the intermittent occlusion and the partial occlusion. Next slide. Here, when I talked about earlier, this is the safety valve. So you see you have the on-off switch. The safety valve is in between the syringe and the on-off valve. So if you're going too quick or too fast, you're automatically going to get a little blowback. A key thing that a lot of people don't seem to forget when they're doing the procedure is you also need to prime that safety valve. When you prime it, it just gets fluid in the valve, and it allows you to give accurate and true. It allows it to work accurately and true. But that's a common mistake we see is people do not prime the safety valve. And what that says to me is a lot of people don't read the instructions, because I'm an instruction follower most of the time. So it behooves you to read the instructions when you do this as well. So it's very good. So next slide.
I think I'm next, aren't I? Do you mind
Yep,
going
you're
back to that
next.
slide real quick? I just
Go
want to
ahead.
highlight a couple of things on that last slide, if you will. So that safety valve, one of the things that happened with the first generation REBOA is that we put this device out in the market. We had a very compliant balloon, and the idea was that the balloon itself would be compliant. That inherently creates safety. And what we found, and I'm sure you've seen pictures of it, is that people would maximally inflate the balloon, and regardless of where they were in the body, and it would be in an iliac or something. And it is, the balloon will expand to a certain point, but if you're maximally inflating every time, then people were exploding iliacs. They were exploding renals. They had some pretty catastrophic outcomes early on. And those who aren't a fan of aortic occlusion, those pictures became like rampant. Like we would use those to say, don't do this, because you can take a case that's something that's complicated to extremely complicated very quickly by exploding an iliac. So that safety valve is something that's pretty undersold. We don't talk about it, I think, enough, but that will not allow the balloon to have more than 1 atmosphere of pressure inside of it. You will never explode an artery. It will just dump out the side of this valve. So even if you're positioned in your malposition, you don't have a confirmation by ultrasound or X-ray, you can safely blow this up. It will go through and occlude. And I've only had it be malpositioned one time, and it was on a pretty anatomically abnormal aorta. But most of the time it just floats right up in the middle in zone 1, and I can go through and do that. I engage the safety valve, but I don't typically overinflate or do anything, so I can just use that safety valve as kind of a mechanism for myself to make sure I'm not going to blow up or hurt anything. All right, you can go to the next slide. So I think I'm going to go through and talk about some clinical stuff. I'm going to try to go slow enough. I know it's virtual, so it creates a little bit more difficulty of interacting, but I'll kind of stop between each slide, just a little bit of a pause. So if you have a question, just throw it out there, interrupt me, and I'll kind of stop. I'm a trauma surgeon, so I do like abdominal, chest, kind of neck and groin surgery for bowel, like heart, lungs, and vessels in the United States for those who are injured. So that's kind of my specialty. Hit next. I don't do any pre-hospital anything. I'm stuck like in the hospital in the trauma bay. Some of the things that have been different, you saw that balloon. So I'm going to talk to you about some of the differences between these two balloons. I know that some of you on the call have used and are currently using the new Pro. So if you have feedback in this and you say, hey, this is what it feels like, then by all means, chime in. I'll tell you how it feels like for me and what I've been able to use it for. When you look at, we've been doing a couple of studies. One of the big studies that we've been doing is called PROMPT. You'll hear the PROMPT analysis is coming out. We've written it up. We've been doing some analysis on it. What that is it's 9 sites, trauma centers around the United States that have been using the Pro catheter for the last 3 years. We have 170 prospective patients and 170 retrospective patients, and we've been following those prospective patients for 30 days. So not randomized controlled. It's really hard for us to do that, but it's kind of the best we could do. Else, we're doing the comparison groups are old catheter versus new catheter. So it's not a no REBOA group. So a lot of the data you'll see is essentially from this trial. So what we've found within this trial is that the earlier we do, so if you look at mortality rates on the left-hand side on the y-axis and across the x is the mortality rate depending on when we did our intervention and the patient's blood pressure and how long our case was. So if we had a short case, like at the very far right, if we had a short case that was less than 45 minutes and we intervened with a blood pressure that was greater than 80, I think that's the right numbers, I'm going to zoom in, then our mortality was 6%. These are 30-day mortalities. So those cases that, and you could possibly argue that that's maybe the population that needed it the least, but they did end up getting it. If you had a really long case being greater than 45 minutes and you intervened when the blood pressure was less than 80, so that red mark, they're more hypotensive and you're doing a long case, that was higher likelihood of mortality. So this data started to kind of indicate that maybe the earlier we intervene on our trauma patients, the better. it's not like a shocker, right? That's not earth shattering. The earlier we stop bleeding, the better. Anybody who's put a tourniquet on somebody would say the same thing. But that's not how we function in the United States. In our trauma centers, we would essentially wait until the very, very end, and then we would put a REBOA in, and then the patient would die, and we'd be like, oh, see, REBOA killed him. And so what we're finding out, just like a tourniquet, we're not putting it on at the very end before the patient rests. We're putting it on when they first come in. We're blowing that up next. So some of the data around that trial kind of sits right here. When Ken talked about an expanded safety profile, this is a little bit what this graph shows to me. So if you give, he talked about the catheter itself, but if you give this catheter to a bunch of surgeons and a bunch of hospitals, this is the data that comes of it. So you give this PRO catheter to people and say, hey, you can use it for 2 hours in zone 1 and potentially 4 hours in zone 3. Then what it looks like is this: our case times actually extend. We start to go through and do longer and longer cases. And when we look at the data, it's not because we just are like fiddling around now. It's because we're starting to intervene earlier. So we were waiting so long in our previous cases, at least when you ask the surgeons in our surveys, was because that half an hour window was so short that they felt like, well, we have to really make sure that they need it, and we're not going to have a lot of time. But once we expanded that window with partial occlusion, and you give people a couple of hours, then they're more than willing to go through and push this early. It's a safer device. And so our case times are looking longer and longer. With that, there's some things you might expect, like, well, maybe our AKI rates are worse, or maybe our mortalities are worse. And they're actually a little bit the opposite. Our AKI rates haven't changed, and our mortalities are improved. Next. With this particular trial too, when you look and see if you give this catheter to people and you just compare the differences, this is not a shocking graph, but you have occlusion times on the y-axis, and then there's a couple different things that we're comparing. The one on the far left is partial occlusion. So if you give somebody the old catheter versus the new catheter, people are going to use the new catheter for partial aortic occlusion far more than the old catheter. It's also not shocking. This catheter is purpose built for partial aortic occlusion. However, people still use it for full aortic occlusion. The slight difference with that in the middle category, the new catheter is used far less frequently for full aortic occlusion. It's typically because we've only started to do full aortic occlusion when our patient's physiology is so deranged they can't tolerate partial. So the way that we clinically will function now is if a patient comes in and let's say their systolic blood pressure is 60, and we're going to intervene and we're going to do partial aortic occlusion, we're going to blow that balloon up, and above the balloon pressure, we're going to keep blowing it up until it reaches between like 90 and 100. But once it reaches 90 or 100, we stop. And so then we'll look below the balloon and say, what is the patient's perfusion pressure below the balloon? Then 20, we say we're good, we're in the state of partial. If we never reach 90, so let's just say they're so hypovolemic and they're so far behind in their resuscitation, we might blow it up completely and we only reach a blood pressure of 75. And the below pressure is like 6. It's not enough for perfusion. That's a complete occlusion state. And that's essentially where this like 16% of people are. We just don't do that very often within our new partial aortic occlusion device. Most people are using it strictly for partial. If you look at our case lengths, our times are overall longer with the new device than it is the old one. And that's statistically significant. Go to the next slide. There's some benefits that we also end up seeing when you look at, we're using it longer, we're using it earlier. So like, okay, that's great, but like, does it do anything? We're finding that we have improved mortalities within both the 6-hour mortalities and the 30-day mortalities with these patient populations. That the mortalities on your y-axis, x-axis is these groups of patients. And so the group on the far left are short cases with the old catheter, which we just didn't have very many, and we didn't have anyone die. If you do a longer case with the old catheter at 6 hours, that's the highest likelihood of died both at 6 hours and 30 days, is long cases and the old device. If you start to then do 6-hour mortalities with the new device, and this is 170 patients, so this is a fairly large group of people, but you end up having a 6-hour mortality that's really low. And I know that this isn't out of hospital cardiac arrest data, so Paul Reese is probably like throwing things at the screen. Clearly my mortality is really good because I'm intervening on patients who are alive. And so this data, literally, yeah, see, this data looks really good because we have purposely chosen those patients who have a pulse and those patients who are currently perfusing. But then if you look to the 30-day mortality, it's not great. I think that most of us would still agree we have a fair amount of work to do between the immediate hemorrhage control and all the other sequelae of trauma, that we're still at like a 45 to 50% mortality in this patient population. So we're still working to go through and figure out how we can drive those numbers down. That's probably not necessarily just an aortic occlusion. It's probably, critical care. They typically dilate from like multi-system organ failure. So I think there's a lot of things that we can work on in medicine in that, but it doesn't look like our population is dying from immediate hemorrhage like they were before. Next. The other thing that we found, and I think this hits to some of the groups that are using this as well, is that when you give this device to somebody, even if they've been using the old device before, there's still some learning that has to happen. So this data is from this group of kind of specialized centers in the United States that have been using both the old device and Pro. And when we gave that to them, we started to look at errors. We started to go through and say, how likely are you to create an error based off of how many times you've used this? So the left graph is just an individual surgeon. And after about 5 cases, the errors plummet. So we basically tell people, expect the first 5 cases that you're going to go through and learn stuff. And that's probably procedurally pretty close to any of the surgeries or procedures that we're doing, is that we're not going to do it the first time right every time. There's also learning that seems to occur, the right graph, as an institution. So even if just one provider is doing cases, we go back. There you go. The one provider is doing cases, the institution's also learning. The institution, however, tends to need about 10 cases to overall stop creating all of these errors and have some difference, but the individual needs about 5. So we do expect that there's some learning that occurs within the first couple of cases. This gets to the point for me when I'm looking at data and I see some of these things and I look at outcomes. That is a question that I ask, is if the number of cases that are done or performed in a study is so low and the number of providers is really big, I essentially ask the question, like, has everyone kind of gone beyond the learning curve? And are we looking at results from learning? Because it's interesting, but I don't want to bank the outcomes of my populations for aortic occlusion just based off of how people learn. I'd rather go through and see what it looks like after those folks have learned and have become more proficient with it. Next. So this one, we've looked at blood product use and plasma use and some different phases of aortic occlusion between these 2 different catheters. So if you look at like before a aortic occlusion occurs versus during aortic occlusion versus after, in all phases of our care of these patients with the new catheter is much less blood product use. Overall, with the plasma use before and after seems to be significantly different, but during inflation, it seems to be about the same. But we're looking at 3 to 5, depends on the numbers we look, of units of blood product on average per case saved when we're doing old versus new. I can't tell you what it looks like if we don't do PREBOA at all, but we're seeing significant improvements with our partial aortic occlusion. And I think this is a little bit important because some of the data or the thought process was like, well, if you're partially occluding, then you're going to go through and just have more and more bleeding. So wouldn't you just use more blood? And it's a little bit the opposite. We've found that we're using less. Next. I also think this gets along with we're using a little bit earlier. If you look at overall survival rates and kind of the survival curve, there's 2 times that patients tend to die that we're putting these catheters in. So blue line is old. I'm sorry, the blue line is the new REBOA, the Pro, and the red line is old REBOA. So those 2 lines that are there, you can see that there's a separation. There's a significant difference in survival rate. More people are surviving with Pro. But in the first 2 days, people are typically dying of intracranial hemorrhage. And some of them are dying from hemorrhagic shock, but actually very few. They're mostly dying of their traumatic brain injury. And then the last phase, they're dying of multi-system organ failure. But during that middle phase, they're within that week, they're pretty steady. So like I said, I think we still have a lot of work to do in the first 48 hours, but we also have work to do, in the first 30 days. Next. So this is probably the two last graphs, and then I'll just get to a case so we can talk a little clinically. But the two last graphs, just trying to go through and show earlier is probably better. And I say probably because we're getting like hints of data. They're clearly statistically significant, but our populations are still fairly small. And so what this did when we saw this within it's like a DoD funded, it's called prompt trial. We said, hey, let's go through and do a second trial. And the trial is conveniently called early, but it's looking at what are the true outcomes if we start to really focus on early intervention within trauma care. So this looks and shows our mortality is improved if you put this in when the patient has a pressure that's greater than 80 versus a pressure that's less than 60. So worse outcomes. And I think the Colombian group also showed that like this kind of 60 to 80 probably kind of the sweet spot for aortic occlusion to optimize your outcomes, that if you really intervene when their pressures are in like the 30s, the likelihood of death is just so high to begin with. So moving that up a little bit within the treatment algorithm has seemed to help. If you go and hit next. So one of the things would be, well, if we are having a patient who has a blood pressure of 80, then aren't we just treating somebody that's like worse, they're not as injured? And so what we did is we just looked at it and said, hey, let's control for ISS. Let's kind of do our regressions in an odds ratio. And so if you control for ISS and you look at those population groups and compare to that low 60 group, you're still less odds of dying if you intervene between 60 and 80, and less odds of dying even more so if you intervene greater than 80, and that's controlling for ISS. So even with that kind of taking into account, there still seems to be that time frame and that blood pressure difference of intervention that seems to be important in this. Next. Any questions on the data? I know that's a lot to kind of throw around in a webinar. Some of it's probably fascinating, I'm sure, to people, and some of it's not. But I know that a lot of us are collecting and building some data sets around it. Some are going to be good, and some are going to show some things that we still have some improvements to be working on. If there's no questions, and you're still welcome to interrupt me, I'll go on to a case. I try not to present cases to say this is the standard of care or I did everything right. These are true my own cases. They're messy. I make mistakes in these cases, but I just put it out there to say, like, you can freely, I take criticism on my cases all the time, but I learn from them when I do them. And so you'll probably pick up some things that you're like a head scratcher on, but this is an example, and this happened like 2 weeks ago, of how I'm using Pro at my center. And maybe I'll try to highlight some of the things that have been happening a little bit differently. So this particular patient was a pedestrian struck right around my hospital. We have a road that's about 45 to 50 miles an hour. And they were kind of walking across the street. They got struck by a car. They came in pretty quickly. Their heart rate was 135. They had some non-invasive blood pressure cuff that was pretty difficult to obtain. They're kind of moving around a lot. Their airway was patent. They had bilateral breath sounds. It was non-English speaking, but he was certainly communicating. We got some adjuncts in our evaluation of a chest x-ray, a pelvic x-ray, and then a fast exam pretty quickly. The chest x-ray, which I'll show you in a second, had a lot of subcutaneous emphysema. The pelvic x-ray overall looked negative for life-threatening injury, and the fast was indeterminate, which you'll kind of probably see why. I literally couldn't see much on the fast exam. So with those, pretty immediately get a common femoral A line in our patients. That is moved up within our algorithms really early, that within the first couple of minutes of someone's arrival, if they're questionable, then they'll just get an A line. And one of my team members will step in. We actually have like an extra person on our team that is there to kind of intervene and do A lines in the highest level activations for these patients. And so then when we get that blood pressure, it's 95/62. The heart rate's still 135. I've been I've presented this case before, and someone pointed out that their shock index is very high. I probably missed that, to be frankly honest. Clearly, the heart rate was high, but the blood pressure looked okay. So I continued on with my evaluations. You can go ahead and hit next. So basically, I didn't intervene on this patient with a high heart rate, a normal blood pressure. Got the chest X-ray, shows a bunch of sub-Q air on the right. You can even see it kind of track below his chest wall. The sub-Q air basically like went to almost mid-thigh. And it was circumferential around his abdomen. So trying to put an ultrasound probe, I literally couldn't see much of anything. So I was a little bit in the dark. And then his pelvic X-ray looks pretty good to me. The quick views and the overall read from the radiologist did not see any broken bones or life-threatening injury. Next. Okay, so with this, I went to CT. We went and got our images, and CT on the left image, you can see there's a liver laceration starting on like Coumadin segment 6, going towards the like portal vein, and that's just another cut of it. But you can see there's a large liver laceration there. You can hit next. And then on the left slide, you can see, I guess I didn't. Will you go back real quick? I don't know if I got a slice through the spleen. Maybe I didn't. Oh, no, you can see the spleen on the right also has a kind of crack right through the middle of it, right to the hilum of the spleen. If you look on the left, sorry, I can't actually, I'm pointing it with my finger. That doesn't help anybody. Hit next. And then the other kind of cuts of the CT, you can see he's got bilateral renal infarcts. I should go through and make sure to tell you, there was no aortic catheter in this patient. They just had a common femoral short line in. Next. And then, oh yeah, sorry, we go back. I just want to point out the pelvic view, which I do look for a lot, is go down the pelvis. There's a fair amount of blood around the sigmoid colon. So grade 5 liver, grade 5 spleen, bilateral grade 4 kidney injuries with those renal infarcts, and blood intraperitoneally within his pelvis as well. Next. So while we're finishing up the CT scan, this is, it happens to me infrequently now, but it still happens that as we're finishing up, the blood pressures are falling. So I'm like, okay, all right, let's go back to Trombe. Let's give him some blood. So we started a unit of whole blood. And as we're doing this, I'm being able to scroll through the CT scans, and I'm like, okay, I gotta go to the OR to go through and take care of this. So I made the decision. I shouldn't say I have to. I made the decision to go to the operating room. I'm sure other people would make the decision to try to embolize some of these things. I made the decision to go to the operating room. And once I make that decision, I go right to aortic occlusion. So before I was going to open up this belly, I'm going to get an aortic occlusion catheter in. So I placed PRO upsized to my 7 French, place it in zone 1. I should kind of highlight with the PRO versus plus. We used to talk a lot about zone 1 and zone 3, the importance of being almost diagnostically correct with your placement of, are you going to be in zone 1? Are you going to go to zone 3? If it's a pelvic fracture, it's only zone 3. And that really was around the time that we had with plus, that when you only had a half an hour, well, you better be picking the right zone, because zone 1 could be dangerous. Now, if the patient's sick, like across the country with PRO right now, if a patient's sick like this, they're not doing well, you're giving blood, their blood pressure is low, we just blindly place it in zone 1. We don't even take a consideration to go to zone 3. If we're then treating and then later on we find out like, oh, okay, really the only bleeding is in the pelvis, then certainly we'll take time to back down and go and only, occlude the pelvis and perfuse everything else. It's just the risks have been so much less. It takes the cognitive load off of the clinician to just say zone 1. If it's a sick patient, we'll go to zone 1 and then we'll kind of go on. So this gives us some control. I'm in a situation where I'm like in the trauma bay, I'm trying to go to the OR, I'm giving blood, I place this up, and the patient's blood pressure does fine. The reason I also will do this prior to me going to the OR, if there's any anesthesiologists on the call, this like calms down the entire room. When I walk in and the patient has a blood pressure of 110 and they've received a unit of blood, it's very different than like MTP rolling, coolers going, and the blood pressure 60, and I'm sweating. And so everything kind of calms down a bit. We don't have to rush as much as we would otherwise. And then I also don't have to worry about post intubation arrest or like peri-induction arrest. I just blow the catheter or the balloon up a little bit more if I need to give it more pressure, because we don't have to go through and chase our tail. So we went to the OR. You can hit next. I'm sorry, but the graphic of bleeding, it was supposed to be something funny within the presentation. So then we got the XLAP. I did see grade 5 liver, grade 5 spleen, bilateral grade 4 kidneys. So I did a hepatography, put some hemostatic agent on the liver, kind of compressed that, did a splenectomy, rotated everything over to look at the kidneys. Those looked fine. I ended up packing that liver pretty tightly. So I packed the abdomen with a bunch of laparotomy sponges, put a temporary abdominal closure on it. As I go through and like pack the belly, I start to gradually deflate that balloon, looking for any other areas of bleeding. I didn't find any other areas of bleeding, so then I put this, it's called Apthera, is what we use, but it's a sponge system and then a drain in to do some direct peritoneal resuscitation that I do in the ICU. The overall case was about 52 minutes of balloon occlusion. I removed the catheter in the OR. My ICU is just upstairs, so I take the patient typically up to the ICU when I'm done in the OR, and then I just remove the sheath in the ICU right there. Next. The overall kind of blood product use, this is pretty typical for us now. I got 2 of whole blood, a packed red blood cell, 2 of FFP, platelets, and 1 of cryo. And that's for pretty big case, I would say. A grade 5 liver, a bunch of blood, a grade 5 spleen. So this is kind of our traditional blood product use now that we're looking at. I did put some labs in the far left just so you don't think I'm crazy. That the pH when he arrived in the OR is that 708, and pH when he was leaving the OR was that 736. So we did end up making some headway. Oh, sorry, 723. We did end up making some headway, and that 736 is the first one we get in the ICU while we're in the OR, and then we can pretty much normalize a blood gas pretty quickly once they arrive. And so then we just returned back, washed them out, closed up the belly the next morning. Wanted to make sure that that liver was stable, didn't have any bile leaks, ended up extubating the patient the day after. I always do duplexes on the arteries after I've put sheaths in them, just to make sure I didn't injure them. It's probably overkill. My vascular surgery friends kind of make fun of me that I don't really need to do that if their clinical exam's fine, but I still end up doing that. And then the quote unquote complication, I put this in there because statistically speaking, on all of our data sheets that we have, this patient definitely had an AKI, but they also had these grade 4 bilateral renal injuries, which on our large databases that we review, we like can't tell the difference. And so this person would be subjected to having a complication of aortic occlusion as an AKI, which I would probably argue wasn't my fault per se, but was secondary to the trauma. Next. I think that's it. Any questions from the group? I know that there's a fair amount of us with different experiences on here, so it'd be fun to have a bit of a discussion how other people are using Pro for myself or Ken. The biggest challenge facing? That's a great question. It's continued adoption and the continued use of the device. So the early use, I will fully admit to you, when as an engineer, what we're taught is to create a minimally viable product. I did engineering for years. Yeah. Oh, yeah. I didn't tell you about my case. I'll tell you about the sub-Q air. He had a big pneumothorax that I neglected to tell you, and a bunch of rib fractures. The biggest challenge, one of the things that I'll say, yeah, lungs. One of the things that I learned as an engineer, when you create a product is a minimally viable product. And that's what we do. We create it and we go. And that's what happened with first generation REBOA. We're on fourth generation REBOA right now. So the world got first generation REBOA, and it wasn't great. I will fully admit to you, there were some things that were wrong with it. There was a lack of guidelines. There's a lack of institutional protocols. Who do we actually use this on? How do we use this? And so we had people all over the world kind of come up and have their own pillars of success. But even within those were just these huge valleys of people having problems. And I think that memory is the biggest problem with REBOA right now, because we're well beyond where we were, and we've advanced well beyond with our catheters. But that memory persists, even to say, hey, if you're one of those unfortunate physicians who had a significant complication, it's hard to get you to try this new thing again. And I don't know if anyone else has other thoughts, because I know a fair number of us are doing REBOA or aortic occlusion, but I would love to hear other people's thoughts on what the biggest challenges are. The other one would be data. I think a lot of us who are academics would say, well, the data is just not as convincing as it could be for aortic occlusion or REBOA cases. And I think that's partially true. I think a lot of things are still adopted well before the data actually hits, if it's convincing enough. But the data for aortic occlusion is just it's has to be massaged a bit both ways. There's a question of what is the current state of play worldwide with pre-hospital application of REBOA? I'm going to have to ask for some audience participation for this one. So I can tell you in the United States, it's a none, zero. That's the easiest of answers. And so I would love to, Ken, like, I don't want to pick on you, Paul, but do you mind helping talk about some of this like pre-hospital state of play, not even just with your own trials, but just generally in the UK?
Yeah, thanks very much for that chance. Hi, Simon, is that you from Hampshire and Isle of Wight? Just give me a thumbs up. So I think you probably know the answer to this, Simon. In the UK, there's a very limited pre-hospital deployment of REBOA in trauma. So London is the most successful service, been doing the longest, initially in zone 3 for pelvic hemorrhage, and then in zone 1 for physiological stabilization and torso hemorrhage. There are some other services, fledgling services, looking at its use. And of course, in East Anglia, we have a study up and running using it as part of management of out-of-hospital cardiac arrest, so using its afterload degeneration for improving coronary perfusion during CPR. So, yeah, not very much in the US. I think there might be one service, not very much across Europe. And I think, yeah, the UK has probably the most developed program. Back to you, Chance.
Yeah. No, and I think, Ken, you can probably help us a little bit in Germany, because he does have a fair amount of contact and work with some folks in Germany.
Yeah,
Peter
well,
Hilbert.
Peter Hilbert's group in Halle, Germany. I mean, with the HIMSS guys there are flying and using it. I would have to look and see. I think we have 2 or 3 cases back from those guys, mostly for, like you said, blunt and then pelvic is where they've used it the most I've seen.
But pretty limited. I think that the expertise certainly lies within Europe for pre-hospital. And I'd like to fully admit that we don't have any physicians that are doing any pre-hospital work. So we are going to be really restricted with our abilities probably for the next decade within the United States. Yeah, it'll be, you guys are going to be well beyond where we could ever be pre-hospital for the next decade, because we would have to change our whole infrastructure. One of the other questions came up during learning curve periods. Yeah, suggest safest patient cohort to first use REBOA. I can tell you what it used to be, and then I'll answer the question of what we would recommend now. It used to be just do it on someone who you think's already dead. And for 5 years, we all taught everybody that, including like the experts in the best course. We just said, well, while you're learning, just the person who you know is probably going to not make it, just use it. And so that's where we got some of these salvage last ditch efforts. Our data across the country didn't look very good. It looked like we were using it really late, people were dying. And so now it becomes one of these, the way that we use this and this kind of safest patient cohort to do is typically in the young patient. If you have penetrating injuries, that's a great one to go through and use it in. But if you have a pelvic fracture, that's probably the number one that in the United States right now, people feel comfortable to say this is our first case to go. The other thing that we haven't talked about at all in this is obstetrical hemorrhage, because it's a planned procedure. And so we have a fair amount of placenta accreta spectrum cases that we're using aortic occlusion on. And that's a great time to like bring one of my new partners in and do a case with them and work together to say, this is how we do this, so they can have all the other feels, not necessarily just the trauma.
Chancellor, you mentioned surgical use
yeah.
as well.
Oh yeah, so surgical adjuncts, sometimes for large tumor resection, especially retroperitoneal, people want to go through and say, we're going to have a hard time getting to the vasculature to get proximal distal control. Can we get a catheter up and for at least some proximal control before we dive into some large tumor resection? So we're also using it as a surgical adjunct. One of the questions was marker. Should we be used to titrate, like example, systolic or diastolic? How can we demonstrate benefit? So in terms of resuscitation, I will tell you, we write all of our guidelines right now on systolic blood pressure. It's absolutely, I don't think, in my opinion, the right thing to do, but that's what we've done. MAP is probably the right, it might be what you're getting to. Mean arterial pressure is probably where we should be working in terms of where we should resuscitate to and what our goal should be. It just makes sense with everything else that we're doing within sepsis treatment or critical care. Why would we have so much focus on systolic blood pressure? It's just been, I think, a historical thing for our guidelines. So now we're at least putting the two together. And the above the balloon, we're really just saying go physiologic. So go to a systolic blood pressure of 90 to 100, a MAP of 60 or 65. And the reason being is we used to get a lot of super physiologic blood pressures proximally. You would blow the balloon up into complete occlusion and they would go up to like 170 or 200 in an instant. And so we don't have that problem any longer. So we don't, especially for our TBI patients, we can get a physiologic blood pressure to that brain, not something that's super physiologic, potentially making their brain bleed even worse. The questions were up to 35. Oh, wow, you're in your out of hospital cardiac arrest. That's amazing. I can't wait, by the way, Paul, to see the results of all of that. I think the world's waiting. And paramedics can safely. So the question for the paramedics safely placing femoral access, this is in the UK or in Europe, because I don't think it's within our paramedics privilege. That Ken, you know better than me.
No, it's not scope in the US yet.
Yeah. So we're even behind there. And then your spear. So Sid, one of the questions was, sorry, I missed the beginning. When can the rest of the world start using? That's going to be a Ken question. Partial REBOA catheter, or is it still limited to high volume centers in the US? I think that's a little bit of the point of this meeting, but I wish I could release everyone right now.
Yeah, the great thing for Europe is, due to our overwhelmingly successful sales in Europe, we are down to less than 9 months shelf life on what remaining stock we have of the Plus catheter. So any new hospital systems, you will automatically default to the new catheter. And so we have a learning management resource center that M3 can get you guys involved with. And then it's just basically getting with your M3 reps. And then once we do just a little bit of training back and forth, it's not going to be a cumbersome process like it was in the past. And then, Chance will do a little bit of discussion with the hospital system. And then, we'll get you guys going. So we're ready to start moving forward in Europe.
Yeah, that's we've been able to do it so it's virtual, like a 5-minute interaction. There's really probably 5 things that you really need to know, those nuances, differences between the two catheters, just to make it successful, to bring your learning curve hopefully to like 2 or 3 cases. And that's the goal of the quick discussion that we have. But it doesn't even have to be like me going there any longer. We've been able to figure those parts out because we don't want to delay any of that. That's not useful for anybody. I would love to spend some time across the pond, but I only get that every once in a while. Yeah. Yep. That's you're in the same boat that we are. So most people in the UK still think of this as the hemorrhage control tool. So yeah, teaching will need to be there. I do think that changing the dialogue around what this looks like, and we've had some success with having that tourniquet level discussion. And I would tell you it's probably more of a stabilization in critical care, like a control tool that I'm seeing it as a tool to like gain control of my chaotic environment. Part of that is maybe involves hemorrhage, but a lot of that is stabilizing their blood pressure for whatever type of shock they're in, and be able to move forward with their care pretty rapidly. And the best part, much like Paul's group, that once you get really good at all of the parts and pieces and you can do them in parallel, it actually goes pretty fast. It's just when you have everything in series and you're like waiting and waiting and waiting, it can be very frustrating to spend 20 minutes trying to get femoral arterial access if you're not good at it. So I also think that hurdle, you heard me say in my center, if I get a feeling that the patient's sick, they're getting a common femoral A line, they're getting a micropuncture, they're getting a small line. That's partly because it gives me a reliable read, but also because my team becomes very facile at doing it. And so they're getting those lines in within 1 to 3 minutes pretty consistently with ultrasound guidance, and they're going through and placing those accurately. We do follow-up PI on all of ours too, to see like once they get a CT to see is it actually in the common femoral. So we're trying to do a lot of work around that. So it's one of these, once you do a lot, you end up doing a lot and you become really good at it. So I think that's also the hurdle we would have to get over, is how facile is everybody at common femoral access. I wasn't very good at it and I thought I was, and then I had to go through and do some extra training. It's a great group.
Yeah, I think really appreciate it. Do we have any more? Anything else before we?
We're always available to.
Yep.
I think that question around getting the catheter, that would be a great follow-up to figure out what's the actual process of using and getting pro. One of the questions was, in your case, what was the time for action to bleeding? I don't actually know. I should look at that in my case. Roughly, I would tell you it's probably 45 minutes. And I only say that because the patient was semi-close to my institution. The region that I cover, it's a mix of urban and rural. Sometimes we have really prolonged pre-hospital times where they're driving or flying to us if they can. And so sometimes it's hours, but I actually know that this was pretty much down the street. So it was probably within a 45-minute time period from injury to placement. But I can look that up, and Ken, if I get that information to you, can you get it out to the group?
Yep.
Okay, cool. I'll look. Yes. Maximum balloon diameter. So the question is, do you have data on maximum balloon diameter? We do. So the things that we test on gets up to 29 millimeters. But we can go through and show, because you can't distend the balloon. You'll cover about 99% of zone 1 aortas. But unlike the other balloons, you can't like distend this new balloon to infinity. It will go through and distend to a region that's about 30 millimeters large, but I can get you that too, so you can see the full specs on it. So 2 follow-ups, Ken. Let's get them to Curtis's balloon schematic so they can go through and see. The other thing we do, if anyone's interested, there's a difference that we've learned with balloon diameters to touch diameter versus occlusion diameter. And so if you end up doing just a touch diameter, which is what most companies will quote you, it's not actually that useful because there's a proximal flow that's hitting it and it's shrinking your balloon down. So we'll give you everything based off of a true flow diameter if you're interested in what aortic size it'll go through and cover. Yep, perfect. Thank you, everybody.
Thanks, guys. Just on behalf of M3, I want to say thanks to everybody for taking time out of their day to attend and for participating with some great questions. And of course, thanks to Chance and Ken for running the show. We'd be happy to get in touch with everybody after this and follow up with the questions. So thanks again, everyone.
Thanks. Have a great day.